for us in the States. My name is Cameron Durham. I work in the Sparkman Center for Global Health, and this is the second installment in our Global Health Seminar series in the fall semester. Just a few quick housekeeping things before we get started. This session is being recorded and will be posted on our YouTube channel for review later. Also, if you have any questions, comments, concerns during the seminar, please use the Q&A box at the bottom of the screen. And I'm also going to turn on the closed captions for you, so you should be able to see those as well. So now I will turn it over to Dr. Janet Tehran, the Sparkman Center Director, to introduce our speaker today.
Thank you very much, Cameron. It is a great pleasure for me to introduce Dr. Mohammed Asim, and he is a medical sociologist, and he conducts research on the intersection of social and health system factors, and then looking at reproductive, maternal, neonatal, and child health. And so he's really done some fascinating research looking at how these kind of the outcomes for reproductive, maternal, neonatal, child health are influenced by the social determinants of health, and with a particular focus on rural areas of Pakistan. And so currently he's developing an area of research around disability and reproductive health, and also with the focus on women's empowerment. And so he is an assistant professor in the Department of Community Health Sciences at Aga Khan University in Karachi, Pakistan. And I had the pleasure to meet him when I was in Pakistan earlier this year, and also we've been working together on developing some research together for many months now. So very excited. And again, if you have, Cameron, can you just, so if people have questions during the talk, they should put them in the Q&A, and then we will pose them to the speaker afterwards. Okay, sounds great. Okay, thank you very much.
Thank you so much. Thank you so much, Dr. Janet Tehran, for a lovely introduction. So I will talk about empowerment and women's health, South Asian perspective. So the outline of the presentation is comprised of two components. The first component is in the context of South Asian, and in the first component, I will present the findings of a paper, and the aim of this paper is what is the effects of women empowerment and modern contraceptive use in poor rich segment of population, evidence from 5 South Asian countries. And the second component of this presentation is a Pakistan case on do empowered women receive better quality antenatal care in Pakistan. So the first paper is we did not submit it. However, the second paper is published earlier of this year in PLOS One journal. So quickly, what is women empowerment? Empowerment is a process by which the powerless get greater control over circumstances in terms of both ideology and resources. Women empowerment promotes women's sense of self-worth, their ability to determine their own choices, and their right to influence social change for themselves and others. However, women empowerment has emerged as a major theme of international development. For example, the Sustainable Development Goal 5 of United Nations seeks to ensure gender equality and empowering all women and girls. The Sustainable Development Goal 5 focus on various areas, for example, ending gender disparity, eliminating violence against women, eliminating early and forced marriage, universal access access to sexual and reproductive health. So moving on to discuss empowerment and women's health. Women empowerment uh, is considered an important indicator of maternal and child health. Various papers have highlighted that and show the significant and positive effect of women empowerment on the use of various health outcomes such as contraceptive, access to and use of antenatal care, skilled birth attendants, facility delivery, as well as the nutritional status of children. However, there is a few evidence on how women's empowerment influence among rich and poor women's modern contraceptive use. The first paper talk about this question. The second paper talks about the role of women empowerment and seeking quality of antenatal care and coverage. So there are lot of evidence related to role of women empowerment and modern contraceptive use, but the it is there is a few evidence on how does women empowerment influence in rich and poor women modern contraceptive use. And similarly, in second paper, there are a lot of evidence on women empowerment and seeking antenatal care, facility delivery, postnatal care. However, there is a little evidence on how empowered women negotiate for seeking quality of antenatal care and quality of antenatal coverage. So the objective of the paper one to explore the association between women empowerment and modern contraceptive use among rich and poor women in 5 South Asian countries. So, so we used demographic health survey data sets for the analysis of both papers. So the population is ever married women, and here is the sample size and year of surveys in the table. Since we use the demographic health survey data of 5 South Asian countries such as Pakistan, Nepal, India, Bangladesh, and Afghanistan. And we did further analysis of demographic health surveys data of recent surveys. And the sample size varies from the lowest sample size was from Nepal, and the highest sample size was from India. That was more than 68,000. So our outcome variable for the first paper was is current use of modern contraceptive method that was classified into 2 categories: 0 non-modern contraceptive use and 1 modern contraceptive use. So we categorized or we classified the variable in terms of non-modern contraceptive use if women are not currently using any method or currently using any traditional method like withdrawal, periodic absenteeism, rhythm, and follicularity. And modern contraceptive methods are including tubal ligation, vasectomy, pills, intrauterine contraceptive device, condom, pill, injectable, lactational, amenorrhea method, and standard D's method. So we use the construction of survey-based measure of women empowerment that is known as SWP or super variable. So we classified this variable into 3 domains: social independence, decision making, and attitude to violence variable. The super index measure of women empowerment that has been validated for global comparison with the DHS data from 62 low and middle income countries. This index uses 14 indicators to create the 3 domains of the women empowerment. So the social independence that is known as a preconception that enable women to achieve their goals, and decision-making empowerment is known as the instrumental agency, and the attitude to violence domain is known as the intrinsic agency. So we uh, then constructed a overall women empowerment variable, and that reflect the that reflect the combination of the power of three domains uh, as the overall women empowerment. So if we talk about how what were the variables in social independence major empowerment. So age at first marriage and age at first birth as a were continuous variable, frequency of reading newspaper or magazines, absolute difference between women and spousal education and age were the variable in social independence domain. In decision making independence, respondents' health care, if women are independent to seek her health care, are able to large household purchase and visiting family or relative. Uh, we constructed the decision making variable from these variables in terms of attitude to violence. For example, if the women burn the food, goes out with telling husband, neglects the children, argues with husband, or refuse to have sex with husband, beating justified or not in each five domains were categorized the lower, middle, and high attitude to violence. All these variables were categorized into three levels of empowerment: lower, middle, and high. And eventually, we also categorize the overall women empowerment variable into three: lower, middle, and high empowerment. So moving on, other covariates and study variables. So we kept place of residence, binary, rural and urban, parity 0 to 1, 2 to 4, 5 plus, and age and education difference between husband and wife as a control variable. Our exposure variable is combination interaction of socio-economic status and women's level of empowerment, and our outcome variable is current use of maternal contraceptive, either yes and no. So data analysis, we analyzed our data into both descriptive and multivariate logistic regression. In descriptive statistics, we run frequency and percentage of level of women empowerment and prevalence of modern contraceptive use. In multivariable logistic regression, each country by including interaction term between socioeconomic status and women empowerments after controlling for covariate. So we adjusted our survey data set for complex through strata, cluster, and probability sampling using individual weights. So each data set of the data set of each country was analyzed separately. So so I will just quickly summarize the key findings. So more than 1/3 women in Afghanistan have lower empowerment, and 1/4 women in Pakistan have lower overall empowerment. Similarly, more than 1/3 women had lower in attitude to violence domain, and more than 50% women in Afghanistan had lower attitude to violence empowerment. Interestingly, 72% women had lower empowerment in social independence empowerment domain in Bangladesh. Again, in Pakistan and Afghanistan has the lowest decision-making empowerment in the region. So current use of among married women across South Asian countries. So the lowest modern contraceptive use was in Pakistan and Afghanistan, where less than 1/4 women use modern contraceptive method. However, the highest modern contraceptive use was in Bangladesh, followed by India, where almost 2/3 women use modern contraceptive methods. So this slide talks about adjusted predicted percentage of modern contraceptive use by level of overall empowerment among poor and rich. So in all South Asian countries, broadly, rich women of all domains of overall women empowerment use modern contraceptive method. Then poor women of all domains of women empowerment except India, where both poor and rich women with high empowerment use modern contraceptive. Where both poor and even poor women with high empowerment slightly using more contraceptive in India. Broadly, we did not find a significant association between overall women empowerment and modern contraceptive use among both rich and poor women in South Asian countries. However, poor women significantly negative association of using modern contraceptive use in high empowerment domain as compared to low empowerment domain in Nepal. For example, if poor women receive high empowerment, they are significantly less likely to use modern contraceptive method. In addition, women's medium empowerment significantly positive association of using modern contraceptive use among poor women having lower empowerment in Afghanistan. For example, if poor women receive medium empowerment, they are significantly more using modern contraceptive method. So in the second table, adjusted predicted percentage of modern contraceptive use by level of decision-making empowerment among poor and rich populations. So decision-making empowerment is an important indicator, and most of the literature shows that decision-making empowerment is the key indicator for different for seeking different health outcomes among women. So, but we did not find a significant association between decision-making, women empowerment, and modern contraceptive use among both rich and poor women in Pakistan, India, and Bangladesh. However, poor women significantly negative association of using modern contraceptive use in high decision-making empowerment domain as compared to low decision-making empowerment domain in Nepal. And similarly, rich women with uh, uh, similarly, poor women with medium decision-making empowerment significantly positive use of modern contraceptive as compared to low decision-making empowerment in Afghanistan. So, for example, in Afghanistan, if poor women have more decision-making empowerment, they are more likely to use modern contraceptive method. However, we did not find significant association for other variable in among both poor and rich women across other different countries in terms of using modern contraceptive methods. So, so here is the similarly in Afghanistan, if rich women receive more empowerment, they are significantly more likely to use modern contraceptive method. So apart from Afghanistan, we did not receive the linear trend of women empowerment of using modern contraceptive use between rich and poor women. So in terms of other types of women empowerment, we also did not find a significant association between attitude to violence empowerment and social independent women empowerment and modern contraceptive use in both poor and rich women. So I did not report because we could not receive a single variable. We did not receive a significant single variable uh, relationship with modern contraceptive use in both poor and rich women. So now I will talk about the second component uh, of the presentation, that is in the context of Pakistan. So the title of the second paper is Do Empowered Women Receive Better Quality Antenatal Care in Pakistan? So as I have earlier discussed, there is evidence on empowered women receive uh, more antenatal care, delivery at health facility, and with lot of other maternal and child health outcomes. However, there is a few evidence on how empowered women negotiate for quality of antenatal care in any country. So since the ANC is increasing in South Asian countries or low and middle income countries, but now there is now the scientists and the researcher are more focusing on the quality of the antenatal and postnatal. So for this purpose, the outcome variable of the quality of the antenatal coverage was comprised on 8 variables, such as blood pressure examination. These are the antenatal like component, and every woman receive these 8 essential antenatal components during first, second, or third, or so and so forth visits. So for example, blood pressure examination, blood examination for iron deficiency, urine examination, received at least 2 tetanus toxoid vaccination shot, consumed iron and folic acid tablet for up to 100 days, received advice on early initiation of breastfeeding, advice on exclusive breastfeeding, and received advice on balanced diet. So if women received less than 7, then we coded as in no, antenatal coverage was not good. And moving on, the second outcome variable, quality of ANC consultation. So it was comprised of 3 variables, like for example, received antenatal care from skilled provider, timeliness, for example, first antenatal care was received during the first trimester, and sufficiency. And if a woman received less than 2 codes, two component, then we marked as a no. Quality of ANC consultation was not available. So here is a percentage distribution of, for example, the first quality of ANC. So though more than 60% women receive ANC, however, in Pakistan, only 41% women receive quality of ANC coverage, and quality of ANC consultation is only 30%. That is like below the coverage. So we have to really focus on the quality of ANC coverage and quality of ANC consultation. So here is a adjusted odd ratio and adjusted odd ratio and 95% confidence interval. So I will only talk about the adjusted odd ratio. So so quality of for example, if women in attitude to violence domain, if women are high empowered, she is more likely to receive quality of antenatal care, and almost 45% more likely to receive quality of antenatal care. In terms of social independence domain of women empowerment, if women are highly empowered, they are receive almost 87% more likely to receive quality of antenatal coverage. In decision-making empowerment, almost 56% women are receive quality of antenatal coverage if they are more empowered in term of decision making. So in term of components of ANC care, so we also found a significant association of all three domains of women empowerment and receiving component of ANC care. For example, if in attitude to violence domain, oh, well, I think there is a typing mistake. So for example, almost 66% women receive more likely to receive component of ANC care if he has empowered to say no in terms of violence, and almost 180% more likely to receive component of ANC care if she is more socially independent in terms of empowerment. So moving on conclusions. So women empowerment influence women's health in multidimensional way. For example, we could not find significant association across all South Asian countries in terms of using modern contraceptive use of among poor and rich women. However, we found significant association of women empowerment with using modern contraceptive, quality of ANC coverage, and quality of ANC components. So women empowerment influence different health outcomes in different ways. Women empowerment does not have linear relation geographically, so it is important to understand the social context. For example, in some parts of South Asian countries such as Pakistan, Bangladesh, and Afghanistan, even privileged and for example, so-called social empowered women don't like to travel alone without male or female companions. So it does not mean these women have lower level of empowerment in the context of that culture. So the women empowerment at some extent is like a contextual factor. So women empowerment is also a culturally driven phenomena that may not associate with various health outcomes, such as like we did thorough analysis and we could not found the linear association of women with different types of the women empowerment with modern contraceptive use among both rich and poor women. There are many other factors that associate with women's health. So maybe women empowerment only does not influence seeking health outcomes or using modern contraceptive methods. So there may be many other factors that also influence women health. So there is a need for qualitative study to better understand what does mean empowerment to women across countries. So there is a lot of evidence on quantitative aspects. However, there is a few evidence related to qualitative findings on how women define empowerment for themselves. So it is important to understand women empowerment context in the context of women across different cultures. Thank you so much. That's it.
Okay. Thank you so much, Dr. Asim. That is really, really fascinating work. And I'll just note that we are recording this, and students and other people will be able to watch it later. So right now, I don't know if a lot of people are in classes because of the time difference wasn't maybe, but they will be able to watch it later. And so you may get more feedback later.
Sure.
Yeah, but I wanted to kick it off a bit and ask, could you talk more about the particular challenges related to women's empowerment and health in the Pakistan setting? I think many of our students may not be that familiar with Pakistan. They don't understand what, women's lives look like in that context. So maybe you could give a little bit of a background about some of the social and cultural environment in Pakistan specifically.
Thank you, Dr. Janet. So, for example, as I little bit discussed earlier, so women like in Pakistan, almost 40% women are literate, and the other development indicators in terms of that are associated with women empowerment is relatively lower. However, like the construct of women empowerment, such as like attitude to violence, sometime like in Afghanistan and Pakistan, women justify wife beating more as compared to men. For example, men are less likely to justify wife beating. However, women in Pakistan and Afghanistan are more likely to justify such practice. So if we think about such type of the trend, then we can say like women empowerment indicators may be a little bit complicated to measure the exact women empowerment in the context of Pakistani and like regional women. So within Pakistan, there is a lot of variation. For example, women who are living in mega cities such as Islamabad, Karachi, and other big cities, they are more aware, they are more educated, they are more independent as compared to the women who are living in rural areas. And almost 66% of the women or like household are living in rural areas.
Mm-hmm.
So
great, thank you. I think Cameron, there are some questions in the Q&A?
Yeah, there are a few. The first one is, what income was used to determine poor versus rich in the study?
Okay, thank you, Cameron. So we used DHS DHS measurement, for example, income was categorized into 5 domain, like poorest, poorer, middle, rich, richest. So when we categorized or break down this variable into 2 variable in poor and rich, we did not consider middle income household. So we categorized poor versus rich, poor, poorest and poorer indexed as poorer, and richest and rich as rich. So we did not include the middle household or middle income women in our analysis.
And so is it for each country, then it's the DHS creates this variable specifically depending on their income levels, right?
Yeah. For example, there are 5 quantile of wealth, and 20% of DHS, like 20% from each domain, more or less 20%. So 20% poorest, 20% poorer, 20% middle, 20% rich, and last 20% richest.
Got it. Okay, great.
And then another question is, what was meant by the term ever married? Does that mean a woman who is not currently married, had been married at some point, divorced, widowed?
Okay, thank you, Cameron. This is a really interesting question. For example, in South Asian context, I think it is not ethically acceptable to ask women, to single women, about the usage of modern contraceptive method. So the question related to modern contraceptive use was only asked from ever married women. So that's why our analysis only comprised ever married women. So we carefully screened the whole data of 5 countries, and we did not found the questions were asked from single women. So then we posted it at a demographic health survey forum, and they replied that they don't ask these questions from some specific countries like South Asian countries, due to like it is not culturally acceptable to ask single women about the usage of modern contraceptive method.
So interesting. Yeah. Wow. Okay.
So that would ever married would mean that they're currently married
or have been married in the past, right?
Yeah.
Right. Yeah. It's both the current ones. It's just anyone who has been married at any time, including currently.
Okay.
Correct.
Yeah.
Correct, Asim?
Yes. You are right.
Okay.
That is interesting. And then there's one more question. So you kind of touched on it at the end of your presentation, but can you talk more about what components would be needed for a qualitative study that would like be across countries, looking at a wider pool of women empowerment?
So thank you, Cameron. I think it may be a little bit complicated if we like study women empowerment across various countries. So maybe, or it can be, but I think women empowerment can be studied in different geographical location. For example, in context of Pakistan, so we did not find any like significant studies related to how women define empowerment through qualitative lens. So there are various aspects. For example, decision making empowerment, that is the most powerful domain of women empowerment. So we can explore some components of decision making empowerment through qualitative lens, and similarly attitude to violence empowerment. For example, almost 43% women justify wife beating is the right of men as compared to 40% men. And similarly, more than 70% women justify wife beating in Afghanistan. So such type of the variables can be uh, can be understand through qualitative inquiry. So why women justify wife beating more as compared to men. So so in this way, we can understand women empowerment construct through the lens of women as well as men through their subjective description.
One more question just came through. So what initiatives does Pakistan currently have in place to address women empowerment? Are these methods generally well received?
Okay, so Pakistan is also the member of the United Nations. So Pakistan is also trying to achieve the Sustainable Development Goal, as I earlier discussed uh, about various domains of the Sustainable Development Goal 5, such as ending gender disparities, eliminating violence against women, eliminating early and forced marriages, securing equal participation and opportunities for leadership. So there are these are broad. So Pakistan, for example, Pakistan is trying to reduce gender disparity, and Pakistan is also uh, have have Pakistan has also done legislation against women violence against women. Pakistan, one province has also set the minimum age of marriage up to 18 years. And Pakistan has also passed the law related to the protection of women property, inheritance property. So, so Pakistan is somewhat doing for the women uh, through legislation. So with Pakistan, different provinces have also set up complaint system for women, a separate police station, separate judiciary system. So I think in last one decade, Pakistan has done uh, or taken lot of initiative for the protection of the rights of the women or women empowerment. And I consider the strongest indicator of women empowerment is educating girls and women. So, however, Pakistan is trying to educate girls, but the stat does not show some great progress. For example, in terms of education enrollment at primary enrollment, girls are less likely to enroll into schools, and in terms of dropout, girls are more likely to drop out from the schools. And in most COVID pandemic, women were more likely to drop out from the school. So Pakistan has to do a lot for educating girls.
Yes, when we visited Pakistan earlier this year, we visited a village, which was actually a village where AKU had been supporting some initiatives, but it was still a very pretty remote village. And just to give you an idea, there was only one school in the village, and it was very basic. They actually had no furniture in the school. It was just an empty room, and it was only for boys. And so they didn't have a school for girls, and if girls needed to go to school, they had to travel quite a distance to actually get to the nearest school for girls. So yeah, that was that was an eye opener to see that and realize that's probably the reality in a lot of places. So even if girls are motivated and families are supportive, it's not easy always for them, I think, to get to schools. But the encouraging thing was when we talked to a group of men in the village, when we asked them, like, what do you need? What are the problems? What do you need? And the number one thing they asked for was a school for their girls. So I thought that was progress, that the men were at least expressing this. So but still, it just was it was an eye opener to what just even the infrastructure of having schools where girls can study is still an issue in some places, I understand.
Yeah, Dr. Janet, you are absolutely right. For example, men, even women, want to educate their children, but there are limited opportunities, particularly for girls. For example, if you boys can make to attend the school, if the school is in their village, so it is very complicated for girls to send the schools that is almost 5 kilometers or 7 kilometers away, and there is poor road infrastructure and lack of resources.
Exactly. So that's important. So one other question I wanted to ask that might be helpful for some of our students and researchers is how easy is it to work with DHS data? And you've done that, I think, quite a lot. And so, like, what's the process? How do you get permission? And how does that work?
Okay, thank you, Dr. Janet. So it is very simple. For example, just go to the DHS website and log in the DHS system, create an account and log in the DHS system. That is very simple. Like we can log in or create an account within couple of minutes. Then we have to simply send a request by sending a very simple abstract to get the data access of a country or some more than one country. So within 24 or 48 hours, the DHS team send an approval email with a letter for using or giving access to download and use the data for the further analysis of the registered project.
And that's great. And I'm gonna put the I'll put the link to the site in the chat. I don't know who all can see that, but anyway, maybe Cameron can also share it with people. And does it have to be something that no one else has researched before? Does it have to be a unique research question?
So I think there is no like we can submit a research question that is simple or complex, so it is up to our proposed analysis. And in terms of submitting the abstract, that is up to 200 or 300 words, not a big proposal or anything. So I would also mention that there is a YouTube channel of DHS demographic health survey. So for example, if a student wanted to understand the DHS data, how does it work, and how like there are a lot of data files. So for the understanding of the purpose, which data file is the suitable for this proposed analysis, there are a lot of extensive YouTube short and very relevant videos, and we can get immersed of using and downloading the data by watching 1 or 2 videos.
And what if they say someone else has already analyzed women's empowerment and modern contraceptive use? Do they not give you permission, or they don't?
No, they don't. They don't care. They don't care. For example.
Okay.
So, Dr. Janet, I think you highlighted a good point. So there is a tab in at DHS website. For example, if we are interested to get know like the trend of the research, or either, for example, we have a research question in our mind and we are trying to understand, did someone work on it or not? So we can go on that tab, use some keywords, and we can see the relevant papers. So DHS also encouraged to run or do data analysis of the same research question when the new DHS data is out.
Right. And and if people, these surveys are done in various countries all over the world at a regular interval. I mean, I think it depends on the country how often they do them, but it's a really rich source of data that can be used for theses and dissertations and research. It's a pretty amazing resource, so people should be aware. So are there, if there are not any other questions, I'm just going to ask one more. Sorry, I have a lot of questions.
No,
okay. So in your paper 1, were the interaction terms significant in some cases between the the income level and the empowerment thing, and how it impacted the contraceptive use? In some countries and some of the analyses, those interaction terms were significant, correct?
For example, broadly, women empowerment, like for example, if women are more empowered, they are more likely to use modern contraceptive method. However, we did not find significant association. We cannot say like it is due to the empowerment. So in Nepal, women empowerment negatively associate with using modern contraceptive method among poor countries. Poor
women. Because I mean, so from what I know, if there are significant interactions, you should not be looking at main effects anyway, right? And I still think you have some important findings to report there. I mean, because if you've got these significant interaction effects that are sort of, they're kind of complicating the main effect. So the fact that you didn't find a main effect between women's empowerment and modern contraceptive use, it may be because of these interactions. So I think that's actually very interesting, and I still think that you have something to publish there, Frank. And maybe focusing on some of the countries, but I think if there are different relationships of this between rich and poor women, and the interactions are significant in some countries, I think that's interesting and important. So I encourage you to to do something with that.
Thank you, Dr. Janet. So our objective was to use this interaction term. For example, if we are trying to change the socio-economic status of women, it is like very complicated or not possible. So for example, however, we can empower women gradually. So our research question was like, if empowerment does empowerment really contribute for using modern contraceptive across South Asian countries or not. So broadly, empowerment plays a important role. However, when we use the interaction term, so we did not find significant result across all South Asian countries.
Okay, well, let's you and I talk about that more.
There was
Yeah.
one more question
Later.
that came through. What was considered modern contraceptive use in the study? Was it female condoms, IUDs, oral contraceptives?
So I can quickly share those slides.
Yeah.
So modern contraceptive using methods include tubal ligation, vasectomy, pill, intrauterine contraceptive device, condom, pills, injectable, lactational, embryona methods, and standard days. These are the modern contraceptive use methods.
And these are the ones that are available. I mean, yes, an implant is not there, or
Implant, I think it is in the list of the modern. Yeah, it is. It is in list of modern contraceptive use. Maybe we are using it with different name, but
yeah, IUD, intrauterine device.
yeah,
that's not an implant. That's an implant is something they implant in your arm. Yeah, that's a different.
Maybe
one.
we missed it. We missed it.
May
But
not be
that, yes, that are the that is in the DHS variable. I know it very well. Maybe I missed it to write over it.
Okay, sounds good.
Yeah, I think that was all the questions. Yeah, the implant in your arm, that was the question. Okay.
All right. Well, thank you so much, Dr. Asim, and thanks you everyone for attending. And we will be in touch and continue the conversation. I really appreciate your sharing this, and I think it's a great model for our students and faculty of the types of things that can be done with DHS data. So thank you very much.
Thank you so much, Dr. Janet. Have a nice day.
Thank you.
Thank you.